Hello and welcome to DIY Therapy. As always, we'll start with our disclaimer. This podcast is for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. My name is Will. With me as always is Andy, and he needs all the medical treatment you can give.
I'm going to take offense to that, actually. Yeah, thanks so much.
Well, we're trying something new here with we're Skyping since we live so far away.
Yes, the 5-minute drive was just too much for us.
It was killing us.
Yeah.
Mostly
Absolutely.
You.
Hey, yeah, well, what can I say? You're right about that. Like, man, too much drive time. Yeah, so we're trying to Skype. We're going to see how this goes. This will allow us possibly to actually get more, podcasts in, which would be kind of nice. We'll be able to do some of them at night and when the kids go to bed and that sort of thing. So hopefully we can get some more content out to everybody. And so that's why we're going to try all this today. So, but what's the topic today, Will?
I think we're talking about new knees.
New knees? What is
Yeah,
new knee?
I got a little bit of arthritis in my knees, so I got to go to the doctor and get a brand new knee.
Give me one of them new ones, huh?
Yeah, well, it's like going to Walmart, right? I need some new tires, so yeah.
Yeah, and so now they've got these beautiful custom ones too that they're putting out there. I actually had a patient the other day ask me if I had any statistics on the customary ones versus the non kind of customary ones. You know anything about that? I don't have any data on that.
I don't either. I kind of assumed that they were all at least a bit custom. I mean, well, not like necessarily custom, but like when they did the X-ray, they did measurements, obviously.
Yeah, but I mean, some of these are being like 3D, like
I don't know,
charted in that regard. But I'll say exactly what I told this other gal that I was treating. The results are getting better and better. I remember, I've been doing this a lot of years, and my first several years, patients were really still struggling with range of motion up to 6, 8 weeks. And now, as you know, we work together in the clinic, we're debating discharging people at 5 to 6 weeks.
Yeah.
Because they've met their range of motion goals. So in general, the surgeons and the techniques are just getting better and better. And people are getting in and out of therapy more and more quickly, which is really nice to see. It doesn't mean the recovery's
any better.
Pain is any easier, especially early on. But certainly they're getting back to at least the majority of their functional daily activities much quicker. So that's a positive. Whether it's a very specific custom knee, or whether it's one of the kind of standard ones that they kind of put in based upon your size and shape, etc. So
one of the questions I always get asked is, well, before people actually get a knee, is like, when do you think I should get a knee?
Good question.
Yeah, and the answer is that it's always up to them. It's like the doctor will tell them, you'll know.
Yeah,
and that's usually a good baseline to go through. You'll know when you need it.
And going for a personal experience, my father actually has had 2 hip replacements, and both times after he had his hip replacements, he said, "Gosh, why did I wait so dang long?"
Yeah.
We hear this a lot from patients too, because after the surgery, obviously you have more surgical pain, but that arthritic pain and that daily grinding arthritic pain that you kind of experience, lessens quite a bit. And then the surgical pain is still there, but obviously that lessens over a period of time. So that's a positive with that. But yeah, it's usually the same. I kind of go by the same rule. It's like, when your pain is at a place where it's affecting the things that you want to do, and you're starting to manage your life and work your life around your knee pain, and then you've gone through strengthening programs and or injections and things of that nature, and they're still not you're still not able to manage your pain. That's when it's time to kind of get that consultation with the doctor at least, and start having the conversation.
Yeah. I think before they even contemplate doing that, they need to get as strong as possible, obviously, because that'll help with recovery and get their range of motion as close to normal as if it's not normal anyway before. Just that way there are better outcomes, obviously.
Totally agree. That's what the research supports. The stronger the knee is prior to surgery, the better the outcomes, the quicker the outcomes, the better, the more quickly that you actually will get back to your normal everyday activities, whether you're still working or you're a retiree. You're going to get back to what you want to be doing more quickly. And in fact, there's recent research, and I've been talking to a lot of patients about this with chronic knee pain prior to surgery, that actually indicated that it was a great study that was done where they and I'm going to botch some of these numbers, so I'm pulling some of these. I don't know these numbers right off the top of my head.
You're just pulling them right out of the air, huh?
Well, they're
1 and 2, 2 and 4, 9 and 3.
But basically, what it said was they took a handful of patients that absolutely the orthopedic surgeon said, "Hey, you needed a knee replacement." They then said, prior to the knee surgery, knee replacement, let's go ahead and take you through a 12-week strengthening program and then see what you want to do. Well, a good portion of those individuals after that 12-week strengthening program actually declined to have surgery. So it gives you some hope that, hey, if you do some things right prior, maybe you aren't a surgical candidate. Maybe that is actually just a tolerance level issue, or maybe it's something that you can strengthen and get strong so that there's more stability in the knee, etc. And that may give you an opportunity to delay that surgery. And what I usually tell people in this case is, especially people who are convinced that they do have to have surgery, because some people just feel like they have to have it, and that's a legitimate opinion and feeling that people have, is okay, well, do what you can, see how strong you get, and if you get strong enough and you don't have any pain, hey, then you have a decision to make. If you continue to go through the exercise regimen and you still have as much pain as you had before, well, then your answer is certainly there. So it's just kind of one of those things where you want to, really make sure you just see where the cards fall, so to speak. Give it your best shot. Get as strong as possible. If your pain lessens and you don't want to have surgery, great. If it doesn't, then you still set yourself up to have a better recovery, because now the knee's stronger than what it was prior to if you didn't actually get it stronger before the surgery. So it's really a win-win in my opinion. So just kind of see where everything falls.
Do we even want to discuss what they actually do in the surgery?
No.
I didn't think so.
No. So this is really so this podcast. Let's back up here for a second. I think this is a podcast one for individuals who are contemplating knee replacement, individuals who have maybe just had knee replacement, or maybe younger folks that they have parents, grandparents that are thinking about doing the knee replacement. This is really kind of an education first podcast in regards to that. In terms of what they actually do, we don't really advise anybody who is truly
no, don't look into it.
Surgery to go YouTube it. You can certainly if you're kind of a glutton for punishment type of person, but don't go looking at it until after you're done with the surgery. It's the one thing I tell a lot of people is it is a traumatic surgery. There's a lot of things going on. You don't need to know the details of it, but from kind of a just a medical standpoint, it's similar to whether or not there was some kind of trauma in the knee, like through an accident. You just chose to have it done in an ER or an operating room setting. So there's still going to be a lot of just physiological responses in terms of swelling and edema and pain that's going to occur after the surgery because of the trauma that is occurring during the during the operation. And so you don't need to know the details of it, but it is important to recognize that it is very traumatic regardless, okay? Regardless of whether you chose to do it or you mangled your knee in a car accident, there's still a lot of trauma there. So there's going to be some physiological responses, edema, swelling, bruising.
Isn't edema and swelling the same thing?
Yeah, I don't know why I listed it like that.
That's the second time you did it. I was going to let the first one slide, and then you did it again, so I'm going to call you on it.
Fair enough. Yeah. So I probably say that just to make myself sound smarter, which is hard to do for me. Anyways. What are some of the first things that you kind of talk to patients about after getting? Because I think this podcast can be something where we basically take them through like the first couple of visits on what to expect.
Yeah, basically.
Because that's the part of the day where patients kind of look at it and go, okay.
I don't know what to do. Yeah.
What the hell did I get myself into?
Yeah, it's usually, yeah. I feel like the first thing they do is they come in. It's something brand new, and they think we're gonna throw something at them that's either scary or dangerous or something to that effect. What I like to do, and I know you like to do, is basically not so much worry about overly strength as much as just range of motion in the beginning. Just get everything working as close to as much as possible, because I think we talked about it before. I think when, like, in the pain episode or something like that, where we were discussing, like, if they've, in a trauma like that, they've not lost any of their muscle mass, so the strength theoretically is there, but they're just not accessing it.
Yeah.
Or something like that.
Well, pain a lot of times will turn off a maximum volitional contraction. So, like, if you were to just pain in general, like if you were to hurt your arm and you were trying to flex your bicep or your upper arm, that contraction just turns off just in the presence of pain. So, certainly from a pain standpoint, that's going to turn off some of the strength. And as the pain lessens, it's really one of those things where a lot of that strength will come back. However, we do need to, that doesn't mean that we ignore it, but early on, as you were kind of alluding to, I really focus on range of motion. One of the things I tell people all the time is, if 6 months from now you have a knee that is really weak, we can take you through like a 4 to 6 week.
That's a relatively easy thing to fix.
Yeah, it can be done at any point, any time. However, if you don't have the range of motion in 6 weeks after, or 6 months after a knee replacement, you may never get it. So, range of motion is really one of the things that we focus on first. One of the other things that I make sure people kind of understand too is that, knee replacements in general are probably, I believe the statistics actually indicate that they're the best orthopedic outcome surgery out there. So, in other words, people have great results with them, and they do very, very well. The two things, in my opinion, that hold people back the most are going to be signs of infection or an infection of any kind. So you need to know what the signs of infection are. So, chills, fever, any type of seepage from the wound, a temperature. If the seepage is a different color, if it's clear, that's usually okay. If it's actually blood coming out, that's usually okay also, because there could be some seepage that comes out from the wound. But, you're looking for a lot of redness too, and an elaborate, or not elaborate, but a huge amount of heat coming off of it. There's always going to be a little bit
there's always
because of the edema. So you just want to make sure you're checking that and you're not having infection. And then the next one would be, of course, falls. The only way you're going to hurt the knee at this point in time is if you fall on.
Yeah, that's people. People always it seems like they're worried about injuring the knee. That any of the stretching exercises or even the strengthening exercises we would do are going to damage the knee. And the only way you're going to do that is if you fall.
Yeah. Yep. So don't take any unnecessary risks. Pick up rugs. Watch the surface changes from like tile to carpet. Those types of things.
Watch for small animals.
Or fairly large animals. Will was holding up a picture of his obese cat.
That's the small one.
That was the small one?
Yeah.
It's hard to tell from the Skype. That was the small one, huh?
I had to throw it back. It was so small.
That's how that works.
It's not big enough to eat yet.
So, and then the other thing that I think is always important to understand, too, is, early on it's really pain management.
Yep. Yep. And what do you think the best way to pain management besides their medication is?
Well, I think one is medication. And there's really, in my opinion, 3 ways that you try to manage the pain early on. The first one is going to be staying on schedule with your medicine. There's such a fear right now with the opioid crisis. Am I overdosing? Am I taking too much? Listen, if you weren't on chronic, or if you weren't taking long-standing pain meds prior to the surgery, and you are fearful of actually becoming addicted or having some type of opioid problem following surgery, you're probably not a candidate that's going